Welcome to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island, ER physician. I work with the Hawaii IPA. Today I'm lucky to have an excellent guest, Mr. Reg Baker, who is extremely experienced in healthcare economics, who is a wealth manager, was the chief operating officer and chief financial officer of a well-respected insurance company in our state, HMAA. Lots of accolades. A lot of you know Mr. Baker because he runs a show as well here on Think Tech. He was U.S. Small Business Administrator for the regulatory branch, two-time chairman of the Hawaii Society of CPAs, chamber leader, Cancer Research Center supporter. So lots of terrific things. Good to see you, Reg.
Yes, I'm tired just hearing about all that.
I love it. So I feel lucky to get you onto the program here today. We're going to share the stage, obviously. You have so much experience in healthcare that we thought maybe doing a two-part piece, first on healthcare economics and focus on macroeconomics, and then a couple weeks from now focus on the microeconomics of healthcare.
That sounds great.
Okay, so why don't we just dive right in. Tell us a little bit about yourself and why you're interested in health economics.
Well, you know, healthcare is one of those vital services that every state and country has to provide to citizens. Access to care is very important. I've worked in the industry both on an insurer, payer side, as well as on a provider side. Although I'm not a provider, I've worked as an administrator in a provider environment. Yes. And I know how challenging it is, and I know how, in a lot of ways, it's a dysfunctional type of industry.
Right.
One of the few that I've ever come across where actually the federal government pretty much dictates the prices that physicians and facilities can charge for their services, right? Which really creates some problems in a raising cost environment. So it's a tough environment.
It is, and I so appreciate your perspective because, as you described, you were on the provider side in Nevada, yes, where you're able to see how it impacts providers directly, and then running an insurance company, knowing exactly what it means to small businesses, what it means to the patients that are members of their plans. I mean, it's incredible. Why don't we flash forward just to what your overall perspective is on the industry itself, like on a national level. Give me your impression. We've had, several years now under the Affordable Care Act, otherwise known as Obamacare. I'm very curious just to know, what do you think of that bill? What do you think of its impact nationally?
Nationally, I think there's probably a little bit more positive than there is locally. Hawaii didn't need it.
Yeah.
And that's, I think, pretty much everybody who's knowledgeable about healthcare in Hawaii will recognize and accept that.
Yes.
On a national level, was probably a bigger need for something. Mm-hmm. I'm not sure that the Affordable Care Act or Obamacare was the solution. I think there was other options that they could have taken a look at. But regardless, it passed, it's been implemented. Yes. It has created problems. I think there's a consolidation in healthcare taking place on the mainland right now. Some of the statistics I've seen in the past, as recently as maybe a year ago, is that they've had more, I'll say bankruptcies or failures or consolidation is another way to say that, of different insurance companies, and I think also different provider groups coming together. They've had more in the last couple of years than they had in the previous 10 years.
Interesting.
A big consolidation has taken place in order to try to address some of these issues.
What do you think the cause of the consolidation is? I like hearing you say that because it reaffirms a lot of the things that I've been concerned about, and in fact have said on some of my programs that probably there was a better road, at least for Hawaii and probably nationally as well. But why those consolidations, and what impact does that have on the actual consumer of healthcare, the patient?
Well, I think the big driver for the consolidations is trying to address the costs and all those different types of costs that surround the Affordable Care Act. Yeah. There's a lot more reporting, a lot more regulation. The Affordable Care Act has set certain what they call metal levels. Yeah. And that's bigger benefits. More care has to be covered at different prices, and so what used to be provided maybe at a lower cost that would cover essential healthcare needs, say for the younger generation that didn't need that much. Right. Now all of a sudden that's not available to them anymore, and they have to take this higher coverage that's got higher costs that they don't really utilize. And so there's this consolidation taking place in order to get economies of scale to play, being able to get bigger populations of covered individuals to spread the risk around a little bit more.
Right.
There's, some of this is statistical. You got to get into the actuarial calculations to really understand it. But in order to reduce the risk and reduce the cost, you have to have bigger and bigger populations.
Right.
And that's what's causing some of the consolidation, particularly on the payer side, and maybe even on the HMO side. Now, some of the practitioners that are practicing medicine, they're getting tired of all the challenges. They don't want to play this game anymore because for some of them who are a little bit older, they're getting close to retirement, they're seeing losses being generated. Their patient base is going to be a little bit older, a little bit require more care.
Sure.
The costs are going to be higher. Sometimes this pay for performance works against them when you've got that older, sicker population.
Sure.
So they're earning less money and paying out more in other costs. And so they're seeing their nest egg eroding, so they're getting out.
Yeah, and getting out is a big concern, as we've seen. We've spoken on this program before about Hawaii's challenge. Our healthcare provider shortage is pegged usually somewhere around 22%, which is anywhere between 600 and maybe 900 physicians. And a lot of people in my organization are saying, I just don't know if I can do it, Josh. I don't know if I can learn another system, deal with another payment model, or even just deal with these challenges that come down from the federal government. Probably going to get into that a lot in our second program when we talk about exactly the impact on providers, but and the individual provider, the individual local hospital. But you've spoken very eloquently about that, and it's interesting to imagine from your perspective what it must look like to see some of these large insurance companies, big companies, need to come together. What would that have been like in Hawaii if that happened?
Well, Hawaii is unique in several respects, and I see at this point, with no offense to anybody, really two big gorillas in a room.
Yes.
You got HMSA and you got Kaiser.
Yes.
And those are the two players. Everybody else kind of falls into lockstep with what they're doing or how they're doing, and not everybody is going to agree with that. But basically, we've got a system in Hawaii where the required plans are dictated by what they call the prevalent plan.
Right.
And that prevalent plan has been out there with HMSA for a long, long time.
Right.
So they set the standard, they set the bar, and everybody else has to come up to that bar and provide that same level of coverage. And that, to me, moves us closer to a monopoly type of environment where you've got one big player that is setting the standard for the product that's being sold,
Right.
In a lot of ways setting the price, and in a lot of ways having control over the providers that provide the service.
Yeah, tell me about it, because as a provider and a part of the Hawaii IPA, we have a very respectful, good relationship with HMSA. However, pretty much what they say goes. And also, in light of the recent announcement, for instance, that Kaiser made, that they, at this point, didn't have the capacity to take any more Medicaid patients, or chose not to take any more Medicaid patients, plus the fact that Kaiser has expressed pretty openly that they like their size currently for the state of Hawaii. Maybe they'll change a little bit because of Maui. Maybe we'll talk a little bit about Maui in a moment. But if they're not expanding significantly and have other agendas and projects that they have to work on right now, that really leaves just one player in the state. Let me ask you this, Reg. When you described the two players, HMSA and Kaiser, as the main players, how would you factor in, say, like a Hawaii Pacific Health? Obviously they're not an insurer. Where do they fall in your kind of hierarchy of players in the state?
I think they have an important role to play. They provide another option for people, but I wouldn't necessarily call them a market leader in the sense of being able to influence very much in the industry. And so, I don't want to discount their role,
right,
but it's really HMSA and Kaiser that has that type of juice to change the industry in the direction it's going. The other players in the market, again, plays an important role, but don't have the leverage.
Great. It's so interesting to hear you speak about these things, because actually I'm really learning a lot from your perspective. And again, by that same model, you have HMSA and Kaiser, then where do you put, say, something like the state, the Medicaid payer? How do you factor them in as Are they just pure trouble, if I may? You know, when put my other hat on as a state senator, or do you consider them separate from this dialogue?
You know, it's hard to disconnect them from the discussion.
Yes.
You know, they do cover a significant part of the population. Have they been troubled in the past? I think maybe they have been a little bit, particularly when we tried to get that health exchange up and running, and they didn't really want to play ball.
Yeah, speak candidly to me about the health exchange. I've got you here. What are your unfiltered feelings about the health exchange?
I think it was a total waste of time and effort.
And money.
A lot of money.
Yeah.
Yeah.
I agree with that completely. Unpack that a little bit for us.
We didn't need it.
Okay.
There were places on the mainland that did.
Yes.
We did not. We already had 95% of the population covered.
Right.
We're only talking about another 5% that needed coverage. There was a lot cheaper ways to do that.
Yeah, and there was natural resistance in my mind. Correct me if this is an incorrect assumption, but if this is 100% insured and you're headed for it, as you get each incremental percentage closer to 100%, it gets more difficult to get those last people in. Therefore, it almost seems to me like it may have been a failed premise that plunking on 150, 200 million extra dollars was going to get those last people insured.
Interesting analogy, maybe. In economics,
yes.
What percentage is considered full employment?
Yeah, tell me, what is it?
Full employment is considered, when you have unemployment of 4%, that's considered full employment, 4%.
Interesting.
Now, the reason why they say that is that there's going to be a systematic change taking place at any time within that employment world, that 4% of the people are going to be unemployed. They're going to either be in between jobs, they're going to be injured and can't work. They may, for whatever reason, decide to take themselves out of the marketplace for a while. And so 4% unemployment is considered full employment in economic terms. So if we had 95% coverage, we're pushing that parameter of what I would consider full coverage.
Because that last bit's fungible. That's just not maybe insurable at any given moment.
You may not be able to find the people. The people don't want to be found. They want to be off the grid.
Yeah.
There may be reasons why, they're here temporarily and then they're leaving. I mean, there could be a variety of reasons that you're never going to reach 100%.
Yet we spent $200 million trying to find them.
We did. And some of the other states simply set up a portal to the federal exchange.
Right.
That would have been a very cheap alternative.
Yeah.
Why we didn't explore that more, I don't know. There's probably money involved and things that were happening that wasn't obvious. Interesting point that I just wanted to raise, and this goes back when Bill Clinton was president.
Yes.
And Hillary was given the torch, the healthcare torch.
Right.
And she paid a visit out here. And she took a look at our Prepaid Healthcare Act and went back to Washington and was using that as the template.
Interesting.
For offering national healthcare coverage nationwide. Why that never caught on, I don't know. Why didn't Obama come back and look at that? I don't know. But we have one of the best models for healthcare anywhere in the country.
And you're referring, before we take our break, to the 1974 Prepaid Health Act?
Yes.
Okay. I'm lucky today to have an excellent guest, Mr. Reg Baker, a prominent member of our community, leader in wealth management, definitely in the industry of accounting, but also as a healthcare industry leader with great experience. I'm Josh Green, Healthcare in Hawaii's host. Thanks for joining us today.
Hi, I'm Chris Leatham with The Economy and You, and I'd like to invite you each week to come watch my show each Wednesday at 3 p.m.
Aloha! I'm Chantel Seville, host of the Savvy Chick Show on Think Tech Hawaii, and I'm going on tour. I'm taking you around the world. We're going to Canada, and then we're going to, we're in America, then we're going to San Francisco. So keep staying tuned, 11 a.m. every Wednesday on the Savvy Chick Show. We'll see you next time.
Aloha! How you doing? Welcome to Hibachi Talk. I'm here, Gordo the Tech Czar on Think Tech Hawaii, and I'm here with my good old buddy, Andrew the security guy.
Hey everybody, how you doing? Aloha.
Good
Thanks
to
for
have
watching.
him. Good to have Andrew here in the house. Please join us every Friday from 1 to 1:30 and follow us up on YouTube. And remember, as we say at the end of every show, how you
you
doing?
Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, physician on the Big Island, state senator. Today I have Reg Baker with me, who's spoken eloquently already in our first 15 minutes about some of the challenges we face here in healthcare in our state of Hawaii. Our first segment, this first 30-minute segment, we're exploring healthcare economics in a macro sense. So again, Reg, thank you for being here. We're going to now talk, I think, a little bit about healthcare costs. And because of your experience as the Chief Operating Officer and Chief Financial Officer, HMAA, you know so much about healthcare costs, and also as a leader at the chamber level. Okay, why don't you, for our guests, unpack it a little bit of why healthcare costs so much? What's going on in America?
Well, you know, there's a lot of, it's not an easy answer. There's a lot of different components to the answer. But one overriding perspective that I think everybody needs to understand is that what was the life expectancy 40 years ago?
Probably 50 something.
50
like that.
something.
Yeah.
What's the life expectancy today? 80 something.
Yeah.
We have made significant progress in healthcare in this country, probably more progress than anywhere else in the world.
Right.
We've got one of the best healthcare systems in the world. We've extended the life of our population by 30 years.
Yeah. In a short time, too.
And that comes with a cost.
Right.
Everybody knows the older you are, the more issues you've got. I mean, my knees don't work as well as they used to. My heart probably getting a little slower. You know, there's healthcare issues that are in the older population that need to be addressed. And as that older population gets bigger and bigger and people are living longer and longer, there are costs associated to that.
Yes.
If you want to save money in healthcare costs, then let everybody die at 55.
I'll tell you, this weekend, less than 72 hours ago, I saw two individuals. One was a 93-year-old gentleman who had, what did he have? He had a replacement of his defibrillator internally. But he's doing great. Now, he came to the hospital because he had constipation. He was having a tough go of it, treating his pain medications, and so on. But he's still having a good life, and he just went through a pretty expensive procedure. And then another very sweet lady who had to just do a little surgical repair on some bleeding that was going on from a surgical site that she just had, but again, well into her 80s, and here at one of our little hospitals, getting very good care, I hope, but not inexpensive.
See, that's success. I mean, we have made significant strides in that area, and it's sometimes hard for me to accept the fact that we're putting a cost on all this. Yeah, it is expensive, but look at the progress we have made and look at the quality of life that we have now that we didn't have 30 or 40 years ago.
For sure. I had an experience where I worked in Africa for a period of time at once, and I can tell you with complete certainty, both of those individuals would have died. They would, of course, never live to that senior age given their health problems, but they would have died in the hospitals with the facilities we had. And so I think that you make a very good point. You know, we're speaking about what we want to be as Americans and what we want to offer our people and our citizens here in Hawaii. So it does have costs. So every time I hear 18% of our GDP is spent on healthcare, I sometimes will caution people and tell them, don't be surprised if it goes up significantly, but also make sure that you address fully whether that is or isn't a negative, because just maybe we want to be another iteration of a generation living well into our 90s or even beyond.
Well, and to your point about the individuals you worked on in Africa, whether they survived, what's the survival rate of people that have severe trauma?
Yes.
Survival rate is much higher now than it was 30 or 40 years ago.
For sure.
And sometimes there's unintended consequences from that survival.
Yeah.
You know, and it requires maybe prolonged health care as a result. I mean, yes, that comes at a cost.
It does. But it also comes, I think, something we can be proud of. It when I do see a family, not every story is a happy one, of course, but when I see a family able to spend that extra time with a loved one, when they've gone through something very traumatic. I mean, I've seen people recover from pretty scary scenarios. It's something. Let's pivot to kind of a global outlook from you. When you look at the healthcare system what are the big areas of improvement that you would recommend on a macro level? What kind of fixes, when you see what's kind of come out of this, this soup of Affordable Care Act and provider shortages and monopolies, where would you start on a macro level?
Gosh, there would probably be 2 or 3 places that I'd like to focus on, but one is that we got to make sure that the people who need healthcare services are provided those healthcare services. And there's a big shortage in little pockets around the country. There's a shortage here in Hawaii.
Yes.
And so we don't have, in my opinion, enough physicians to address all the issues.
And that could drive costs too, right? Because if we did a good job and helped underserved areas, we would expect probably an increase in healthcare spending nationally.
Yep. But there's options to provide some of that service. And if we could just look at some of the regulatory issues that we've got to deal with, that it would allow maybe a remote access capability, a virtual doctor's appointment, or doing things, that might provide maybe not 100%, but provide 50 or 60 or 70% of the services.
Yes.
At a much reduced price.
Right.
And those are some trade-offs that we got to look at. Again, with the regulations, with all due respect, a physician doesn't have to touch every patient. You can have a PA or an MP involved in some of this, and as long as they're properly supervised and trained and monitored, you can address maybe 80% of what needs to be addressed.
I didn't know whether you were going to bash the government or physicians there, so but I was prepared for both. No, I think you're totally right. Hawaii's been interesting in that I've been a participant in this dialogue and even sponsored some of these bills. We've allowed nurse practitioners a broader scope of service, because from my perspective, when you're short, and if someone can't, for instance, get important critical care, say on basic questions like hypertension, diabetes, very smart providers that may be nurse practitioners instead of instead of family practice doctors or internists, they still can do an extraordinary amount, maybe every bit the full complement of work. And what I tell my physician colleagues, if they complain about it, I say, well, look, believe me, they will also capture the very challenging and end-stage challenges that you haven't seen otherwise, that you never had time to get out to Ka'u to see, or to Waianae. And they may bring people into the system that you'll be able to help as well.
Exactly.
So I think that's pretty valuable. But what impact would that have on, we're already spending $3 trillion a year, nationally. Are we okay to spend a little more in order to help more people, or do you actually think it might decrease costs if we had a better system?
Well, let me ask this question. I'll kick it back to you.
Sure.
What costs more, a healthy community or an unhealthy community?
Yeah.
And I think so. It may take some time, and there
Right.
may be an initial cost outlay, but as everybody gets more healthy and we're able to control some of the disease that's out there,
Yes.
that overall the tide's going to come up, everybody's going to get lifted, we're going to have a more healthy community, which I think is going to impact costs and drive it down.
For sure. And, first of all, I agree with that premise. I think that your analysis is spot on. But even if the costs were to rise, but we had a very dramatic improvement in health, we might see economic growth, we might see a great decrease in waste or lost time at the workplace. We might just even say to ourselves, it was a moral imperative to take care of all those individuals that got crummy care for decades.
And here's another piece that we can't forget, is that how many other social services would also have drop in their costs as a result of everybody getting healthier and getting employed and being productive.
Yes.
I think there's, you can't just define healthcare costs and the savings in just that one bucket, because there's other related buckets that got to be factored in.
Yeah, you're very right about that. As you were saying that, the one I was thinking about was Medicaid, for instance. Right now, this is the state legislator in me, we spend $2 billion on our Medicaid budget. We have 345,000 people in a pretty small state, about 1 in 3 now, that are otherwise able to get some other insurance now on Medicaid. If these individuals were able to have a healthier life, if they were working productively, we have nearly, as you demonstrated earlier, a nearly 100% rate of insurance in the workforce. I don't know if we have enough jobs for everybody, but we could be expanding industries, and we could have individuals, I think, many happy individuals if they were working a great job, getting paid $40, $50, $60, $80,000 a year so that they could afford to be insured, they'd be happier than being on Medicaid. And by the way, our Medicaid budget could drop down.
You know, and what's interesting, excuse me, what you just said, if we were able to get some percentage of those people back into the workforce,
Right.
do we have the jobs for them? I don't know. I do know that we've been running at full employment in Hawaii for quite a while.
Yes.
I know the construction costs are way up. There's this thing called the rail that's having some challenges right now with
Yeah.
labor costs.
Right.
And we've been told this because everybody's employed, everybody's out working, they can't find the people. Well, if we got these people healthy and put them back to work, there could be a drop in some of these costs that we're seeing out there.
Interesting, yeah. And some of the projects could get accelerated. I think that the bottom line on your message is run a good system, and what comes out of it, if costs go up a little bit, maybe productivity takes care of it, or decrease in waste, but running a good system is more sensible than running an inefficient system with waste, loss, and all of these other problems.
Absolutely.
We have only a few more minutes in our first segment, which is macro healthcare economics. Advice to the leadership in our state. What advice would you give them in the next couple years as we're going to have a new president? We're going to have our governor will be more experienced in his role. What would you recommend to them on healthcare?
I would suggest, and this may be a big request, but try to take politics out of the equation. Do what's right for the people that need the health care. Do what's right for the people who's going to be paying for the health care. You know, not everything is a political decision.
Yeah.
And I speak specifically to our very quick knee-jerk buy-in to the Hawaii Health Exchange. I think we were the first state in the entire country that totally agreed with that and go full bore into it. And it has created a lot of problems for us.
Yeah.
And I think that was more of a political decision than it was a thought-out solution to our healthcare needs.
Yeah, I think you're right. And I think that is a very excellent example because it was visible. We had a lot of input to the contrary, and subsequently that probably wasn't the way to go. I believe HMSA pulled out ultimately.
Yeah.
I know that it probably put at least one insurance company under in our state. And what did that lead to? Less competition, less options for our business community.
And everybody's paying more for healthcare.
Okay. Well, I think this has been an excellent first step as we talk about the macro health economics. I've had the good fortune of having Reg Baker here on my program today, who in his own right is an expert in our business community. I work from the healthcare side almost exclusively, and when we come back in 2 weeks, Reg and I are going to talk about the microeconomic challenges that our healthcare system faces here in Hawaii and across the country. Thanks for joining us on Healthcare in Hawaii.